augmented by placing of cotton pledgets soaked with anesthetic in the area to be grasped. Topical phenylephrine may also be instilled to shrink the conjunctival vessels. In younger children, a general anesthetic is required. Let us understand the force duction test in the context of a long-standing right lateral rectus palsy. You are suspecting a contracture of its direct antagonist, the right medial rectus. If present, this would limit abduction. So we need to passively abduct the eye to test how far we can do so. First, ask the patient to move the eye in the direction of limited movement, in this case to the right. This serves two purposes. The maximum range of voluntary movement can be determined, and the antagonist, in this case the medial rectus, relaxes by Sherrington's law and thus eliminates resistance to passive movement, which can interfere with interpretation. The limbus is now grasped opposite to the direction of movement. So here the medial rectus is grasped with a tooth forceps. Some people prefer to grasp the muscle tendon itself, but this is more traumatic and more painful for the patient. The globe is then passively rotated in the direction of limited motility, taking care not to push it posteriorly, as this can produce a false negative result due to slackening of the recti. If you are not sure whether you are involuntarily pushing the globe down or not, you can even propose it slightly with the forceps. Here you can see that the globe is able to be abducted more than the patient can voluntarily, but not fully, and a resistance to further abduction is felt. This is called a positive force duction test. This is because of medial rectus contracture. This is in contrast to what would have been the situation in the early stages of the lateral rectus palsy prior to medial rectus contracture, where full abduction would have been possible. This is called a negative force duction test. The resistance is felt when the eye is moved in the direction opposite to that in which the mechanical restriction is present. However, sometimes when there is a retro-equatorial adhesion, a reverse leash effect can be seen when there is a restrictive element on the same side as the limitation of movement. To test for lateral rectus contracture when adduction is limited, for superior rectus contracture when infraduction is limited, to test for inferior rectus contracture when supraduction is limited. Alternately, some people use two forceps at opposite meridians perpendicular to the movement limitation. For example, for horizontal restriction, two forceps are used at 12 and 6 o'clock. If the force duction test is positive, one can proceed to the active force generation test. This requires active cooperation of the patient and hence can only be performed in conscious patients. Here, two forceps are used to hold the globe steadily in the primary position. The patient is then instructed to look in the field of action of the muscle to be tested. For example, here the patient is asked to look to the right because we are testing the lateral rectus muscle. A weak or absent tug suggests the presence of a muscle weakness or a paretic component. This force may be compared with that of the other muscles. One can also use the same muscle in the other eye for comparison when in doubt. The active force generation test may be performed either before or after a force duction test. What we have seen till now is FDT for the recti. Guyton described an exaggerated force duction test for the obliques. The patient should be lying down with the examiner performing the test from the head end. First, we'll see how to test for tautness of the superior oblique of the right eye. The globe is grasped at the 3 and 9 o'clock positions in the primary position. The globe is pushed back into the orbit, then extorted, then brought supero-nasally. The globe is then brought temporally when a click will be felt and the tautness can be assessed. Now to test for tautness of the inferior oblique. The globe after retropulsion is